This is a clinical briefing on the 2025-2030 U.S. Dietary Guidelines. Our objective today is to distill the core, practice-changing updates for your immediate clinical application. So the central thesis of these new guidelines is a fundamental policy reset. The core directive is a major shift away from complex nutrient calculation toward a whole food-based dietary pattern. Now, this directly addresses the failure of previous nutrient-centric models, which, as we know, inadvertently permitted the proliferation of highly processed foods that were technically healthy. The primary message for patient counseling is now completely unambiguous: prioritize whole foods. We'll proceed through 6 sections. We'll start with the paradigm shift, then cover core quantitative targets, key food group recommendations, and the new limitations and prohibitions, which we should really frame as Class 3 equivalent recommendations. Then we'll hit the pediatric updates and finish with an actionable clinical summary. Okay, Section 1, the guideline paradigm shift. This really is a move from that abstract, nutrient-centric model to a tangible, food-centric one that's designed for much more straightforward clinical application. The explicit goal here is to counteract the metabolic consequences of the standard American diet. The guidelines are very clear that prioritizing whole, nutrient-dense foods is now the primary strategy for mitigating diet-driven chronic disease. And this slide really illustrates the core heuristic. On the left, you see the recommended pattern of whole foods. On the right, the prohibited category, highly processed foods. This side-by-side is going to be your central counseling tool from these new guidelines. Moving to Section 2, dietary targets. Let's review the specific, quantifiable targets that are going to provide the framework for all your clinical counseling moving forward. All right, for a standard 2,000-calorie pattern, the baseline targets are as follows: 3 servings of vegetables, 2 of fruits, 3 of full-fat dairy, and 2 to 4 servings of whole grains. Remember, these are baseline recommendations, and you'll need to adjust them for individual energy requirements and clinical status. For protein, the guidelines specify a clear quantitative target, 1.2 to 1.6 grams per kilogram of body weight daily. This metric is absolutely critical for counseling on the maintenance of lean body mass and, of course, satiety. Section 3. Here, we're going to detail the clinical nuances and the specific guidance within major food categories. We're moving beyond just simple serving counts now. Regarding protein, the guidance really emphasizes source diversity from both animal and plant origins. Preparation methods that don't involve deep frying are strongly recommended. And critically, the formulation matters. Meat should be consumed without added sugars, refined starches, or any chemical additives. For dairy, the recommendation is a significant departure from previous guidance. It explicitly endorses full-fat products, with the key proviso that they have no added sugars. For fats, the focus is squarely on whole food sources. Recommended cooking fats now include olive oil, butter, and beef tallow. The upper limit for saturated fat is maintained at less than 10% of total daily calories. Let's move to Section 4. This section details what we can consider the Class 3 recommendations. These are the foods and ingredients that are contraindicated or must be strictly limited. The primary prohibition targets highly processed foods. This category is defined as those packaged, ready-to-eat products that are high in added sugars, sodium, refined carbohydrates, and artificial additives. This is a true cornerstone of the new guidelines. Now, a key quantitative limit has been set for added sugars. The directive is that a single meal should contain no more than 10 grams of added sugars. This is a clear, actionable, and frankly, an enforceable counseling point. To operationalize that sugar limit, we have to educate patients on label interpretation. Common terms for added sugars are going to include various syrups, sugars ending in O's, and concentrates. Familiarity with this list is absolutely essential for effective counseling. The sodium limit for the population aged 14 and older remains less than 2,300 milligrams per day. But it's critical to note that specific lower age-dependent limits are now in place for the pediatric population, and those are detailed in the full text. Section 5. We now turn to one of the most significant updates in the guidelines, the detailed recommendations for infancy and early childhood, from birth to 4 years of age.
The feeding timeline is very clearly delineated. You've got exclusive breastfeeding or formula for the first 6 months. Then at approximately 6 months, complementary foods should be introduced. A significant practice change here is the recommendation for early introduction of peanut-containing foods between 4 and 6 months for infants at high risk of allergy, specifically those with severe eczema or an existing egg allergy, and this is to be done following clinical consultation. Then at 12 months, the transition is from formula to whole milk. The guidelines also provide clinicians with specific observable milestones for developmental readiness for complementary feeding. These include things like postural control of the head and neck, the ability to sit with support, and key oral motor skills like moving food to the posterior pharynx for swallowing.
For this population, the key takeaway is an absolute prohibition. No amount of added sugars or caffeinated beverages is recommended during infancy and early childhood. This is a Class 3 recommendation with 0 exceptions. Finally, Section 6. Let's do an actionable summary consolidating the key practice changes that you can integrate immediately. All right, here are your top-line takeaways. 1. The primary mandate is to shift your counseling to a real food paradigm. 2. Target 1.2 to 1.6 grams per kilo for protein. 3. Recommend full-fat, unsweetened dairy. 4. Strictly prohibit or limit highly processed foods. 5. Enforce that less than 10 grams per meal limit on added sugars. And 6, for pediatrics, you need to counsel on early allergen introduction at 4 to 6 months for high-risk infants. This concludes our briefing. The final point for reflection is this: how will this new food-based paradigm shift really alter your clinical counseling for chronic disease prevention and management?